Good afternoon. For the next few minutes, I would like to share a story that is not only pertinent but personal. I come from a family who suffers a great deal of mental illness. My father, when living, and one of my living siblings has been in and out of homelessness all of their lives. Living below the poverty level as a family of seven was not easy, but there was food and shelter. My father and brother could have lived at home, but often chose the streets. This is not uncommon. City and even some suburban streets are full of homeless people. Some choose it due to mental illness and or drug addiction. Some are driven to homelessness through bad choices and some end up homeless as a last resort of poverty and or loss of jobs. There are many reasons with no easy answers. Proactive health communication plans can help those in need and the cities that deal with them. As potential medical care providers, it is part of our job to support the communities in which we live. One way to do that is to become involved in creating and implementing proactive health communication plans. Although homelessness is a problem for much of our country and even the world, for today's discussion of the homeless population, we are looking specifically at San Diego County. Due to the temperate weather and relative ease of living, many homeless migrate to San Diego from other areas of the country. We have homeless veterans, singles, young and old. We see children of all ages, families, and those who are mentally and physically ill. According to the San Diego County annual census conducted every January, there were 9,116 homeless in 2016. That number is projected to rise by at least 10% each year if the county does not do something to intervene. Different sources cite radically different numbers in regard to breakdown of mentally ill, physically ill, lost jobs, wages, etc. The census estimates that 80% of San Diego's homeless are mentally ill and or drug addicted. In the case of my father, he was mentally ill and an alcoholic. My brother is mentally ill, but to the best of my knowledge does not have an addiction issue. In both cases, inability to maintain employment and poverty contribute to the downward spiral. Homeless are subject to any of the health concerns that we see in the general population. They have heart disease, diabetes, cancers, etc. All are exacerbated by risks of being without basic care, good food, shelter, etc. Imagine having diabetes with no access to medication and extremely limited food sources, or having kidney failure with no access to dialysis, medication, and not a healthy meal. Clean water can become a problem, particularly for good hygiene, such as hand washing, bathing, and brushing teeth. We are currently experiencing a severe outbreak of hepatitis A in San Diego. Many of the affected are homeless, and the cause has been determined to be a lack of proper facilities for good hygiene, at least in part. This often affects those living in poor communal conditions. Flus and viruses are more easily spread through the homeless population. Again, due to proximity, poor living condition, and lack of good hygiene practices, with decreased immune systems due to poor health and or poor diet, the homeless are easy victims for these flus and viruses. Any bacteria or parasite or virus can be easily caught by those with decreased immune systems. Be it physical or mental, the health of a homeless person is extremely at risk. Lack of medical care, poor diet, hygiene, and a state of hopelessness often contributes to substance abuse and suicide. All these risks have a negative impact on what the person may be currently experiencing, physically and mentally, or both. Alleviating or at least lessening these risks may not cure the homeless problem, but it will help address the health issues of the homeless, which in turn may help some of the individuals improve their condition in life. For the severely ill, both physical and mental, and for the drug addicted, there is great need for increased effective inpatient care to help treat their conditions. Most often, when my family members came back home, it was by way of an inpatient mental health treatment facility. Follow on care can be tricky. Either it's not there or it's hard to access. In our case, both family members would stop taking their medication and soon end up on the streets again. Dobson 2010 is one of many good references that discuss the theories and concepts we apply to social situations, as well as individuals, when discussing behavior and modification. In building a proactive health communication plan, it is helpful to consider a theory and create a framework that supports the tenets of that philosophy. For my plan, I am using two theories: Maslow's hierarchy of needs and Bandura's social cognitive theory. Maslow speaks about base needs being met before we can achieve a higher level. In the case of homelessness, the very basic needs of clean air, food, water, shelter, clothing, and sleep must be met before we can expect them to move to higher levels. What does this mean for a health plan? Well, we must help them meet their base needs before we can expect them to engage in anything else, including a health plan. Bandura talks about human behavior from the perspective of social cognition, specifically how thought processes affect behaviors that affect environmental factors. You can look at this from any of the three thought processes: behaviors, environment as the beginning, or thoughts as the beginning. A fluid system where one factor continually affects the other is what will result. These two groups of people live completely different lives. There is almost nothing in day to day life that is the same for a homeless person and a person of some affluence. However, take away the job, money, security, all resources of the affluent, and they too may become homeless. Meaning, we are all people and should have a basic understanding of what each other need to survive. My approach to the community health plan is twofold. Number one, bring in basic resources to the homeless, without which they cannot focus on higher level issues. Number two, use social cognition and modeling to present my plan to the City Council, thereby getting the resources I need to fund basic needs for the homeless. I will sell this to the City Council not only through human compassion, but by using Maslow's hierarchy of needs to explain that a population who has nothing cannot thrive and improve their condition without having their basic needs met. Let's use the recent hepatitis A outbreak as an example. In order to get the homeless in line to receive their vaccines, the city offered a hot meal after vaccination. Some stations had stand-up showers. Some offered things of value like a goodie bag with snacks, moist wipes, hand sanitizer, and food coupons. All the areas were set up with a portable hand washing station. Before getting the vaccination, the homeless were shown how to properly wash their hands to improve hygiene and stop the spread of disease. These hand washing stations can be seen all around the city. They were left in hopes that our homeless would use them. They are currently in constant use. Meeting people where they live, literally in this case, has begun to lower the numbers of hepatitis A cases seen in our county. Using the approach of meeting basic needs to communicate with a population who has little to nothing of extrinsic value is compassionate and intelligent. The goal of reducing new cases of hepatitis A is achieved while those homeless vaccinated were given something they needed immediately: food, clean water, plus the vaccine to help protect them and those around them. Shivo 2016 discusses user-friendly and relatable communication between provider and patient. In my proactive health plan, I will use signage in the homeless areas that are readable and relatable to all. The sign on the left has pictures and words. Even if someone cannot read or does not understand English, the pictures do a good job of conveying a message. Compare that with the sign on the right. This may be something I use at the City Council to explain hepatitis A and use to get resources to fund my plan, but it wouldn't be a good choice for the community. Some of the homeless may well understand it, but it is not generally relatable or attention grabbing for someone who is struggling with day to day life. If you're hungry, thirsty, need shelter and personal safety, reading difficult signage with medical jargon is not going to be something that you will readily do. As a future provider, I am hopeful to share proactive health communication plans with those who have the ability to allocate resources for our homeless populations. At the local, state, and national, as well as world level, we must effectively communicate to survive and thrive as a people. Every day, in some way, however small or grand, do your part to help someone less fortunate than you. If you have nothing of extrinsic value to give, share your time and your attention. Truly listening to someone can change their life for the better and is often the best gift you could ever give someone. Be the you that you want to see in others. Thank you for your time and attention to my proactive health communication plan. It has been a pleasure to present this to you today. I hope you enjoyed it.